Hello dear friends, this is a case of a 23-year-old young female patient who presented with severe abdominal pain since 4 days ago, with worsening symptoms, vomiting, unable to keep down solids, has not passed opened the bowels the last 4 days, and CT scan was done to rule out any bowel obstruction. I will scroll the images just to make your first quick impression, and I will switch to coronal view as well. Just pay attention to the small bowel. Okay, this is the first scrolling of the images in the axial view. And here in coronal view, we will discuss the images. Just make your first impression here and pay attention to the small bowel. As you can see, there is significant dilation of the small bowel, which is intermittent when we analyze the images, and there is significant fecalization of the small bowel. All these are small bowel loops here, with significant amount of fecal material. So there is dilation of the small bowel and significant amount of fecal material. This is the right colon, the cecum, and here is the ileocecal valve. There is no evidence of any tumor or any obstruction here, but anyway we can see fecalization of the terminal ileum as well. Here it is. But if we track the ileum backwards, we can see that there is collapse and there is intermittent dilation of the small bowel. Not all the bowel loops are dilated like in this region here. Here is the large bowel after and past the point of the right colonic curvature. Here there is a significant fecalization of the large bowel in the right colon, but further to the mid-transverse colon, the large bowel is almost empty. Just gas intraluminally in the large bowel. There is a small impression that there is also some reactive wall thickening of the small bowel, like in this region here. So the above findings are suggestive of reduced small bowel outflow, and the findings could be associated with underlying small intestine bacterial overgrowth, or SIBO, S-I-B-O. However, in this patient, other underlying pathology cannot be definitely excluded, and we can discuss the differential diagnosis a little later. Now, as for the SIBO, let's call it SIBO, small intestine bacterial overgrowth. The underlying cause includes multiple pathological entities. Some of them are motility disorders, immunosufficiency, obstructive causes like tumors, mural thickening due to inflammatory bowel disease, liver pathology, and bile acid fluid deficiency causing malabsorption, excess use of antibiotics, ileocecal valve insufficiency, so bacteria can be transmitted from the large bowel to the small bowel. Some authors have found that this pathology, the SIBO, can be associated with irritable bowel syndrome, and the usual symptoms of the patient is abdominal pain, discomfort, bloating, alternative diarrhea and constipation, steatorrhea, and smelly feces, and excessive flatus. There is mild hepatomegaly and evidence of mild inhomogeneous fat infiltration of the liver. As you can see, there is ill-defined focal hypotenuation adjacent to the falciform ligament here. This is a typical case, typical site of inhomogeneous fat infiltration of the liver. No other obvious pathology has been detected in this CT scan in this patient. So in conclusion, cases like this, intermittent dilation of the small bowel with significant fecalization, possible intermittent mural thickening, can be associated with small intestine bacterial overgrowth, and this diagnosis should be included to our report. Dear friends, thank you for watching this video. See you next time.